Front, lateral and medial sides of leg and dorsum of foot. Introduction. The great saphenous vein starts on the medial side of the dorsum of the foot and runs up just anterior to the medial malleolus, where it can be slit open for transfusion purposes. Dorsalis pedis artery, the distal continuation of the anterior tibial artery, is used for palpation in some clinical conditions. The dorsiflexors of foot supplied by deep peroneal nerve lie in the anterior compartment of leg. Tibialis anterior is an invertor of the foot as well. The two big evertors of the foot with superficial peroneal nerve are placed in the lateral compartment of the leg. The tendons of all these muscles are retained in position by two extensor and two peroneal retinacula. The three muscles inserted on the upper medial surface of tibia stabilize the pelvis on the thigh and leg. Surface landmarks. 1. Medial and lateral condyles of tibia are felt better in a flexed knee with the thigh flexed and laterally rotated. 1. Tibial tuberosity is a bony prominence on the front of the upper part of tibia, 2.5 cm distal to the knee joint line passing through the upper margins of the tibial condyles. The tuberosity provides attachment to ligamentum patelli above, and is continuous with the shin below. 2. Head of the fibula lies posterolaterally at the level of tibial tuberosity. It serves as a guide to common peroneal nerve which winds around the posterolateral aspect of the neck of fibula. 3. Shin is the subcutaneous anterior border of tibia. It is sinuously curved and extends from the tibial tuberosity to the anterior margin of the medial malleolus. It is better defined in the upper part than in the lower part. 2. Medial surface of tibia is subcutaneous, except in the uppermost part where it is crossed by the tendons of sartorius, gracilis, and semitendinosus. Great saphenous vein crosses lower one-third of the surface, running obliquely upwards and backwards from the anterior border of medial malleolus. 3. Medial border of tibia is palpable throughout its whole extent. The saphenous nerve and great saphenous vein run partly along it. Gastrocnemius and the underlying solar flow form the fleshy prominence of the calf. These muscles become prominent when heel is raised as standing on toes. Tendocalcaneus is the strong, thick tendon o1. These muscles, it is attached below to the posterior surface of calcaneum. 4. Medial malleolus is the bony prominence on the medial side of ankle. It is formed by a downwards projection from the medial surface of the lower end of tibia. 5. Lateral malleolus is the bony prominence on the lateral side of ankle. It is formed by the lower end of fibula. It is larger but narrower than the medial malleolus, and its tip is 0.5 cm below that of the medial malleolus. The posterior borders of 2 malleoli are in the same coronal plane, but the anterior border of lateral malleolus is about 1.5 cm behind that of the medial malleolus. 6. Peroneal trochlea, when present, is felt as a little prominence about a finger breadth below the lateral malleolus. Peroneus brevis passes above and the peroneus longus below the trochlea. 7. Sustentaculum fully can be felt about a thumb breadth below the medial malleolus. 8. Tuberosity of navicular bone is a low bony prominence felt 2.5 to 3.75 cm antero-inferior to the medial malleolus, about midway between the back of the heel and root of the big toe. 9. Head of the talus lies above the line joining the sustentaculum tali and tuberosity of navicular bone. 10. Tuberosity of the base of fifth metatarsal bone is the most prominent landmark on the lateral border of the foot. It lies midway between the point of the heel and the root of the little toe. 11. Posterior tibial artive pulsations can be felt against calcaneum about 2 cm below and behind the medial malleolus. 12. Dorsalis pedis arfe pulsations can be felt best on the dorsum of foot about 5 cm distal to the malleoli, lateral to the tendon of extensor hallucis longus, over the intermediate cuneiform bone. 13. Tendon of tibialis anterior becomes prominent on active inversion of the foot, passing downwards and medially across the medial part of the anterior surface of ankle. 14. Tendon-phelloxer/ta ipsis iongus becomes prominent when the foot is dorsiflexed. 15 Extensor digitorum brevis produces an elevation on the lateral part of the dorsum of foot when the toes are dorsiflexed or extended, Fig 8.7. 16 Irci metatarsophalangeal loinae lies a little in front of the center of the ball of big toe. The other metatarsophalangeal goins are placed about 2.5 cm behind the webs of the toes. Superficial fascia dissection. Make a horizontal incision across the leg at its junction with foot. Provide a vertical incision up from the center of incision, 1, to the middle of incision drawn just below the level of tibial tuberosity. Carry this vertical incision onto the dorsum of foot till the middle of the second toe. Reflect the skin on both the sides. Look for various veins and cutaneous nerves in the leg and foot according to the description given in the text. Contents. The superficial fascia of the front of the leg and the dorsum of the foot contains the superficial veins, cutaneous nerves, lymphatics, and small unnamed arteries. Superficial veins. 1. The dorsal venous arch lies on the dorsum of the foot over the proximal parts of the metatarsal bones. It receives 4 dorsal metatarsal veins, each of which is formed by the union of 2 dorsal digital veins. 2. The great or long saphenous vein is formed by the union of the medial end of the dorsal venous arch with the medial marginal vein which drains the medial side of the great toe. It passes upwards in front of the medial malleolus, crosses the lower 1/3 of the medial surface of tibia obliquely, and runs along its medial border to reach the back of the knee. The saphenous nerve runs in front of the great saphenous vein. 3. The small or short saphenous vein is formed by the union of the lateral end of the dorsal venous arch with the lateral marginal vein, draining the lateral side of the little toe. It passes upwards behind the lateral malleolus to reach the back of the leg. The sural nerve accompanies the small saphenous vein. Both saphenous veins are connected to the deep veins through the perforating veins. Cutaneous nerves. 1. The infrapatellar branch of the saphenous nerve pierces the sartorius and the deep fascia on the medial side of the knee, curves downwards and forwards, and supplies the skin over the ligamentum patellae. 2. The saphenous nerve is a branch of the posterior division of the femoral nerve. It pierces the deep fascia on the medial side of the knee between the sartorius and the gracilis, and runs downwards in front of the great saphenous vein. It supplies the skin of the medial side of the leg and the medial border of the foot up to the ball of the great toe. 3. The lateral cutaneous nerve of the leg is a branch of the common peroneal nerve. It pierces the deep fascia over the lateral head of the gastrocnemius, and descends to supply the skin of the upper 2/3 of the lateral side of the leg. 4. The superficial peroneal nerve is a branch of the common peroneal nerve. It arises on the lateral side of the neck of the fibula deep to the fibers of the peroneus longus. It descends between the peroneal muscles, pierces the deep fascia at the junction of the upper 2/3 and lower 1/3 of the lateral side of the leg, and divides into medial and lateral branches. These branches supply the following area: the skin over the lower 1/3 of the lateral side of the leg. The skin over the entire dorsum of the foot with the exception of the following areas. Lateral border supplied by sural nerve. Medial border up to the base of the great toe, supplied by the saphenous nerve. Cleft between the first and second toes, supplied by the deep peroneal nerve. 5. The sacral nerve is a branch of the tibial nerve. It arises in the middle of the popliteal fossa. It runs vertically downwards, pierces the deep fascia in the middle of the back of leg, accompanies the small saphenous vein, and supplies the skin of the lower half of the back of leg and of the whole of the lateral border of the foot up to the tip of the little toe. 6. The deep peroneal nerve terminates by supplying the skin adjoining the cleft between the first and second toes. 7. The digital branches of the medial and lateral plantar nerves curve upwards and supply the distal parts of the dorsum of the toes. Medial plantar nerve supplies medial 31/2 toes, lateral plantar nerve supplies lateral 11/2 toes. Saphenous nerve may be subjected to entrapment neuropathy as it leaves the adductor canal, leading to pain in the area of its supply. Deep fascia. Dissection. Underlying the superficial fascia is the dense deep fascia of leg. Divide this fascia longitudinally as it stretches between tibia and fibula. Expose the superior extensor retinaculum 5 cm above the ankle joint and the inferior extensor retinaculum in front of the ankle joint. Features. The following points about the fascia are noteworthy. 1. In the leg, tibia and fibula are partly subcutaneous, the most notable being the medial surface of the tibia, and the malleoli. Over these subcutaneous areas, the deep fascia is replaced by periosteum. 2 extensions of deep fascia form intermuscular septa that divide the leg into compartments. The anterior and posterior intermuscular septa are attached to the anterior and posterior borders of the fibula. They divide the leg into 3 compartments, anterior, lateral, and posterior. The posterior compartment is subdivided into superficial, intermediate, and deep parts by superficial and deep transverse fascial septa. 3. Around the ankle, the deep fascia is thickened to form bands called retinacula. These are so called because they retain tendons in place. On the front of the ankle there are the superior and inferior extensor retinacula. Laterally, there are the superior and inferior peroneal retinacula. Posteromedially, there is the flexor retinaculum. The extensor retinacula are described below. The peroneal retinacula are considered with the lateral compartment of the leg and the flexor retinaculum with the posterior compartment. 4. Superior extensor retinaculum. 5. Medially, it is attached to the lower part of the anterior border of the tibia, and laterally to the lower part of the anterior border of the fibula, forming the anterior boundary of the elongated triangular area just above the lateral malleolus. 6. Inferior extensor retinaculum. 7. This is a Y-shaped band of deep fascia, situated in front of the ankle joint and over the posterior part of the dorsum of the foot. The stem of the Y lies laterally, and the upper and lower bands, medially. Attachment. 1. The stem is attached to the anterior non-articular part of the superior surface of the calcaneum, in front of the sulcus calcanei. 2. The upper band passes upwards and medially, and is attached to the anterior border of the medial malleolus. 3. The lower band passes downwards and medially and is attached to the plantar aponeurosis. Structures passing under. 1. Tibialis anterior. 2. Extensor hallucis hungus. 3. Anterior tibial vessels. 4. Deep peroneal nerve. 5. Extensor digitorum longus. 6. The peroneus tertilis. Anterior tibial compartment syndrome/Fresher syndrome. The muscles of anterior compartment of leg get pain because of too much sudden exercise. The muscles are tender to touch. Dissection. Identify the muscles of anterior compartment of leg as these are lying close together on the lateral surface of tibia, adjoining interosseous membrane and medial surface of fibula. Trace their tendons deep to the 2 retinacula on the dorsum of foot till their insertion. Learn about these muscles given in tables 8.1 and 8.2. Muscles of anterior compartment of the leg. The muscles of the anterior compartment of the 1 are the tibialis anterior, the extensor hallucis longus, the extensor digitorum longus and the peroneus tertius. These muscles are tested by palpation on the front of leg and requesting the patient to dorsiflex the foot, Fig 8.6. The attachments of these muscles are given in anterior tibial artery. Introduction. This is the main artery of the anterior compartment of the leg. The blood supply to the anterior compartment of the leg is reinforced by the perforating branch of the peroneal artery, the size of which is inversely proportional to that of the anterior tibial artery. Beginning, course and termination. The anterior tibial artery is the smaller terminal branch of the popliteal artery. It begins on the back of the leg at the lower border of the popliteus, opposite the tibial tuberosity. It enters the anterior compartment of the leg by passing forwards close to the fibula, through an opening in the upper part of the interosseous membrane. In the anterior compartment, it runs vertically downwards to a point midway between the 2 malleoli where it changes its name to become the Dorsalis pedis artery. Relations. In the upper 1/3 of the leg, the artery lies between the tibialis anterior and the extensor digitorum longus. In the middle 1/3 it lies between the tibialis anterior and extensor hallucis longus. In the lower one-third it lies between the extensor hallucis forgis and the extensor digitorum longus. In understanding these relations, note that the artery is crossed from lateral to medial side by the tendon of the extensor hallucis longus. The artery is accompanied by the vena comitans. The deep peroneal nerve is lateral to it in its upper and lower thirds and anterior to it in its middle third. Branches. 1. Muscular branches supply adjacent muscles. 2. Anastomotic branches are given to the knee and ankle. The anterior and posterior iliacal recurrent branches take part in the anastomoses round the knee joint. The anterior medial malleolar and anterior lateral malleolar branches take part in the anastomoses round the ankle joint or malleolar networks. The lateral malleolar network lies just below the lateral malleolus. The medial malleolar network lies just the medial malleolus. Deep peroneal nerve. Deep peroneal nerve is the nerve of the anterior nerve compartment of the leg and the dorsum of the foot. This is one of the two terminal branches of common peroneal. It corresponds to the posterior interosseous nerve of the forearm beginning, course and termination. Deep peroneal nerve is one of the terminal branches of common peroneal nerve. It begins on the lateral side of the neck of the fibula. It enters the anterior compartment by piercing the anterior intermuscular septum. It then pierces the extensor digitorum longus and comes to lie next to the anterior tibial artery. In the leg it accompanies the anterior tibial artery and has similar relations. The nerve ends on the dorsum of the foot, close to the ankle joint, by dividing into the lateral and medial terminal branches, Fig 8.4. The lateral terminal branch turns laterally and ends in a pseudoganglion deep to the extensor digitorum brevis. Branches proceed from the pseudoganglion and supply the extensor digitorum reris and the tarsal joints. The medial terminal branch end by supplying the skin adjoining the first interdigital cleft and the proximal joints of the big toes. Branches, muscular branches supply, 1-4 muscles of the anterior compartment of the leg. The extensor digitorum brevis on the dorsum of the foot. A cutaneous branch supplies adjacent sides of the first and second toes. Articular branches supply the ankle joint, the tarsal joints, the tarsometatarsal and metatarsophalangeal joints of the big toe. Paralysis of the muscles of the anterior compartment of the leg due to injury to deep peroneal nerve results in loss of the power of dorsiflexion of the foot. As a result, the foot is plantar flexed. The condition is called foot drop. This is usually caused by injury or disease of the common peroneal nerve due to trauma, leprosy or peripheral neuritis. Sensory loss is confined to first interdigital cleft. Dorsumo foot dissection. Identify the small muscle extensor digitorum brevis situated on the lateral side of dorsum of foot. Its tendons are deep to the tendons of extensor digitorum longus. Its most medial tendon is called extensor hallucis brevis. Dissect the dorsalis pedis artery and its branches on the dorsum of the foot. Dorsalis pedis artery. This is the chief palpable artery of the dorsum of the foot. It is commonly palpated in patients with vaso-occlusive diseases of the lower limb. It is a continuation of the anterior tibial artery onto the dorsum of the foot. JA beginning, course, and termination. The artery begins in front of the ankle between the two malleoli. It passes forwards along the medial side of the dorsum of the foot to reach the proximal end of the first intermetatarsal space. Here it dips downwards between the two heads of the first dorsal interosseous muscle, and ends in the sole by completing the plantar arterial arch. Relations. Superfacial, 1 skin, fasciae, and inferior extensor retinaculum. 2 extensor hallucis brevis, which crosses the artery from the lateral to medial side. Deep, 1 capsular ligament of the ankle joint. 2 the talus, navicular, and intermediate cuneiform bones and the ligaments connecting them. Extensor hallucis longus. Lateral, 1 first tendon of the extensor digitorum longus. 2 the medial terminal branch of the deep peroneal nerve. Branches, 1 the lateral tarsal artery is larger than the medial and arises over the navicular bone. It passes deep to the extensor digitorum brevis, supplies this muscle and neighboring tarsal joints, and ends in the lateral malleolar network. 2 the medial tarsal branches exe 2 to 3 small twigs which join the medial malleolar network. J3. The arcuate artery is a large branch that arises opposite the medial cuneiform bone. It runs laterally over the bases of the metatarsal bones, deep to the tendons of the extensor digitorum longus and the extensor digitorum brevis, and ends by anastomosing with the lateral tarsal and lateral plantar arteries. It gives off the second, third, and fourth dorsal metatarsal arteries, each of which divides into dorsal digital branches for adjoining toes. The dorsal metatarsal arteries are joined by proximal and distal perforating arteries from the sole. 1. The ars dorsal metatarsal artery arises just before the dorsalis pedis artery dips into the sole. It gives a branch to the medial side of the big toe, and divides into dorsal digital branches for adjacent sides of the first and second toes. Clinical anatomy. Pulsations of the dorsalis pedis artery are easily felt between the tendons of the extensor hallucis longus and the first tendon of the extensor digitorum longus. It must be remembered, however, that the dorsalis pedis artery is congenitally absent in about 14% of subjects. Dissection. Reflect the lateral skin flap of leg further laterally till peroneal muscles are seen. Divide the deep fascia longitudinally over the peroneal muscles. Clean the superior and inferior peroneal retinacula situated just above and below the lateral malleolus. Identify the peroneus longus and peroneus brevis muscles. Trace their tendons through the retinacula towards their insertion. Study the deep fascia and peroneal muscles. Boundaries. The lateral or peroneal compartment of the leg is bounded anteriorly by the anterior intermuscular septum, posteriorly by the posterior intermuscular septum, medially by the lateral surface of the fibula, and laterally by the deep fascia. Contents. Muscles, peroneus longus and peroneus brevis. Nerve, superficial peroneal nerve. Vessels, the arterial supply is derived from the branches of the peroneal artery which reach the lateral compartment by piercing the flexor hallucis longus and the posterior intermuscular septum. The veins drain into the small saphenous vein. Peroneal retinacula. The superior peroneal retinaculum is a thickened band of deep fascia situated just behind the lateral malleolus. It holds the peroneal tendons in place against the back of the lateral malleolus. It is attached anteriorly to the posterior margin of the lateral malleolus, and posteriorly to the lateral surface of the calcaneum and to the superficial transverse facial septum of the leg. The inferior peroneal retinaculum is a thickened band of deep fascia situated antero-inferior to the lateral malleolus. Superiorly, it is attached to the anterior part of the superior surface of the calcaneum, where it becomes continuous with the stem of the inferior extensor retinaculum. Inferiorly, it is attached to the lateral surface of the calcaneum. A septum attached to the peroneal tubercle or trochlea divides the space deep to the retinaculum into two parts. The peroneal retinacula hold the tendons of the peroneus longus and brevis in place. Under the superior retinaculum the two tendons are lodged in a single compartment, and are surrounded by a common synovial sheath. Under the inferior retinaculum each tendon lies in a separate compartment. The tendon of the peroneus brevis lies in the superior compartment and that of the peroneus longus in the inferior compartment. Here each tendon is enclosed in a separate extension of the synovial sheath. Tenosynovitis of peronei tendon is the inflammation of the tendon sheaths of the peroneal muscles. If superior peroneal retinaculum is torn, the tendons can get dislocated to front of lateral malleolus. Peroneal muscles, these are the peroneus longus and the peroneus brevis. Their attachments are given in tables 8.3 and 8.4. Paralysis of peroneus brevis and peroneus longus occurs due to injury to superficial peroneal nerve. The foot cannot be everted at subtalar joint. Superficial peroneal nerve. Dissection. Carefully look your common peroneal nerve in relation to the neck of fibula. Superficial peroneal nerve, one of the terminal branches of common peroneal nerve, supplies both the peroneus longus and brevis muscles, and in lower one-third of leg becomes cutaneous to supply most of the dorsum of foot introduction. Superficial peroneal nerve is the main nerve of the lateral compartment of the leg origin. It is a smaller terminal branch of the common peroneal nerve. Course. The nerve begins on the lateral side of neck of fibula, runs through the peroneal muscles and becomes superficial at the junction of upper 2/3 and lower 1/3 of leg. Relations. It begins on the lateral side of the neck of the fibula, under cover of the upper fibers of the peroneus longus. In the upper 1/3 of the leg, it descends through the substance of the peroneus bs. In the middle 1/3, it first descends for a short distance between the peroneus longus and humerus muscles, reaches the anterior border of the peroneus reris, and then descends in a groove between the peroneus brevis and the extensor digitorum under cover of deep fascia. At the junction of the upper 2/3 and lower 1/3 of the leg, it pierces the deep fascia to become superficial. It divides into a medial and a lateral branch which descend into the foot. Branches and distribution. Muscular branches, peroneus longus and the peroneus brevis. Cutaneous branches, through its terminal branches, the superficial peroneal nerve supplies the lower 1/3 of the lateral side of the leg and the greater part of the dorsum of the foot, except for the territories supplied by the saphenous, sural, deep peroneal nerves and plantar nerves. The medial branch crosses the ankle and divides into two dorsal digital nerves, one for the medial side of the big toe, and the other for the adjoining sides of the second and third toes. The lateral branch also divides into two dorsal digital nerves for the adjoining sides of the third and fourth and fifth toes. Communicate in branches. The medial branch communicates with the saphenous and deep peroneal nerves and the lateral branch with the sural nerve. Superficial peroneal nerve supplies both peronei and then divides into medial and lateral cutaneous branches for supplying dorsum of foot. Superficial peroneal nerve can get entrapped as it penetrates the deep fascia of leg. It may also be involved in lateral compartment syndrome. Its paralysis causes loss of eversion of foot at subtalar joint. Dissection. Identify the three tendons of a tripod formed by sartorius, gracilis, and semitendinosus to their insertion on the upper medial surface of tibia. Behind these tendons is present the tibial collateral ligament of knee joint. The great saphenous vein is visualized on the lower 1/3 of tibia. Study these structures. Features. Medial side of the leg is formed by the medial surface of the shaft of tibia. The greater part of this surface is subcutaneous and is covered only by the skin and superficial fascia. In the upper part, however, the surface provides attachment to tibial collateral ligament near the medial border, and provides insertion to sartorius, gracilis and semitendinosus in front of the ligament, all of which are covered by a thin layer of deep fascia. The great saphenous vein and the saphenous nerve lie in the superficial fascia as they cross the lower 1/3 of this surface. The skin, fasciae, and periosteum on this surface are supplied by saphenous nerve. The tibial collateral ligament, morphologically, represents degenerated part of the tendon of adductor manus. Partly it covers the insertion of semimembranosus, and is itself crossed superficially by the tendons of sartorius, gracilis, semitendinosus, and with unserine bursa around them. Guy ropes. The three muscles inserted into the upper part of the medial surface of tibia represent one muscle from each of the three compartments of thigh, corresponding to the three elements of the hip bone. Sartorius belongs to anterior compartment of thigh, and is supplied by the nerve of ilium or femoral nerve. Gracilis belongs to medial compartment of thigh, and is supplied by the nerve of pubis or obturator nerve. Semitendinosus belongs to posterior compartment of thigh, and is supplied by the nerve of ischium or sciatic nerve. These three muscles are anchored below at one point, and spread out above to span the pelvis, like three strings of a tent. From this arrangement it appears that they act as guy ropes, to stabilize the bony pelvis on the femur. Unserine bursa, this is a large, complicated bursa, with several diverticula. It separates the tendons of sartorius, gracilis, and semitendinosus at their insertion from one another, from the bony surface of tibia, and from the tibial collateral ligament, Fig 8.14.5. The great saphenous vein ascends in front of the medial malleolus and crosses lower 1/3 of the medial surface of tibia obliquely with a backward inclination. The surface nerve run downward juice in front of great saphenous vein. The vein is accompanied by lymphatic from the foot which drain into vertical group of superfacial inguinal lymph nodes. bursa ons rind between insertion of sartorius, gracilis, semitendinosus and tibial collateral ligament may get inflamed. It is called ons rena bursitis. Structures under our extensor retinaculum of ankle, tall Himalayas are never dry places. Tibialis anterior. Extensor hallucis longus. Anterior tibial artery. Deep peroneal nerve. Extensor digitorum longus. Peroneus fertius. Superior and inferior extensor retinacula and superior and inferior peroneal retinacula retain the tendons in place during movements of various joints. Dorsum of foot contains a extensor digitorum brevis, while dorsum of hand has no muscle of its own. Long and short saphenous veins start on the dorsum of foot. Long saphenous vein lying anterior to medial malleolus is used for giving intravenous fluid/blood in case of one emergency. Medial surface of tibia is bare. It is crossed by long saphenous vein and saphenous nerve in the lower one-third of leg. Guy ropes, formed by sartorius, gracilis, and semitendinosus stabilise the pelvis on the thigh and leg. Dorsalis pedis is palpated on the dorsum of foot on medial cuneiform between extensor hallucis longus and extensor digitorum longus.